Okay, good morning, everybody. Welcome on this glorious early winter, late fall, I guess, morning. So we are in the midst of the second wave, in case you hadn't noticed. So welcome to Grand Rounds. We made it very apropos. I am absolutely delighted to introduce to you Dr. Ilan Schwartz, who is our one of our junior faculty members within the Department of Medicine. Dr. Schwartz is an assistant professor in the Division of Infectious Diseases. He was recruited to the University of Alberta in 2018 after completing his clinical training in Manitoba and at Queen's University. And then he did a PhD from the University of Antwerp while studying emerging fungal diseases in HIV patients in South Africa. This was followed by further training in clinical mycology in San Antonio, Texas. So from mycologist to obviously we know infectious diseases experts are multipotent. They can take on whatever they need to. His research interests are around invasive fungal infections, immunocompromised patients, and global health. And he's been involved in several clinical trials of outpatient therapies for COVID-19. So we asked Dr. Schwartz to talk about COVID-19 therapeutic options. And so without further ado, I'll hand it over to him.
Okay, thank you very much, Dr. Casson. So thank you for the introduction. My name is Ilan Schwartz. I'm an infectious disease physician. As Dr. Casson mentioned, I prefer to be studying fungal diseases, but we all have shifted our attention to COVID, and it's been quite a learning experience. So I do not have any conflicts to disclose. The general objectives for this talk, there's going to be three themes that seem to recur. The first is that it's very difficult to generate high quality RCT data in a pandemic. And we'll go over some of the reasons for why that is. Some of them are intuitive, some a little bit less so. And secondly, I'm going to show you again and again that really there is no substitution for high quality RCT data. And it's really the gold standard for attributing cause and effect, as we learned in med school, but really COVID-19 has given us these lessons really in real time, in plain sight. And we're going to learn the current landscape of therapies available. This, of course, is a very short list, and we'll go into what has worked and what hasn't. I'm going to be discussing both antivirals and host-directed therapies. I am not going to be talking about ventilation strategies or anticoagulation. And there's literally dozens of therapies that have been proposed or are in various phases of investigation that I'm not going to be talking about. I'm going to be focusing my talk on a few select antivirals and a few select host-directed therapies, including those that have demonstrated the most promise and some that have shown the most disappointment. So we've really been in an unprecedented situation with COVID-19 where we've been completely inundated with information. There's been over 80,000 publications to date about COVID-19, many of them pertaining to therapies, many of them in preprint servers. And it's akin to trying to drink from a fire hose or from a fire hydrant. And you end up feeling like your thirst has not been quenched just because it's we're completely overloaded, but it's hard to take a lot of this information in. And a lot of it is very low quality as well. But early in the pandemic, it became quite clear that there's sort of two different types of clinicians when it comes to approaching data. There are those that really would like to do something, even if it means acting on poor, flimsy data, and those that are quite skeptical and really need a high burden of proof in order to adopt new therapies. And this has been very difficult to find that sweet spot in between. Okay, so I was just saying that basically there's two different approaches. One is to be a little bit more hawkish when it comes to interventions, even when they don't have as much data behind them, given the unique circumstances of the pandemic. As a result, a lot of different individuals and a lot of different hospitals have been doing different things around the world in terms of adopting therapies. And we saw this initially when comparing even national level guidelines that really varied from place to place. And it really was the Wild West. So of course, there are a lot of challenges to generating RCT data. And so I don't want to appear to be overly critical. As we know, a lot of places were completely slammed initially with the first wave. Individuals as well as systems were overwhelmed and weren't prepared to see the sort of onslaught in cases that they did see. Another problem that we've had, particularly in Canada, is that our system of regulatory oversight, which we'll all agree is indispensable, has not been able to keep up with the sort of agility that's required for the rapid change in pace in the setting of the pandemic, where new therapies have been introduced, others have been debunked very rapidly, and there's been a lot of changes in terms of the dynamics of the pandemic itself. Of course, we know there's lots of costs that are involved, particularly when evaluating non-generic medications. And this is one of the reasons why hydroxychloroquine was embraced by so many trialists early on, is because there were not a lot of options for therapies that were off patent. And in order to get money for trials, this of course takes time. And so a lot of individuals were operating out of their war chest, and that severely hampered the ability of a lot of individuals and a lot of groups to be able to contribute. Unfortunately, we are in an academic culture that rewards individual accomplishments, publications, for instance, funding, and often this is at the cost of collaborations that may be more fruitful, especially in a pandemic. Not to minimize the effect of the fact that this is a novel pathogen, and really there were a number of unknowns initially. We had no idea about the event rates, and accordingly the necessary sample size. For example, in our outpatient trials of hydroxychloroquine, based on the initial data to come out of China, we had estimated that that somewhere around 15% of patients would require hospitalization. And what we found out is that was really a much too pessimistic expectation, and really was about a tenth of that that ultimately would need hospitalization, and consequently the sample sizes required to demonstrate an effect are much larger than what we had anticipated. There have been challenges with identifying the correct endpoints to use. This was most notable in the NIH ACT trials, which initially used a 15-day recovery as the anticipated primary endpoint. And the investigators soon learned that that really wasn't realistic in this disease. And so they changed it to time to discharge, when really it should have been mortality. But again, these are decisions made with incomplete data. And then the best problem of all, which was experienced in China early on, is that a lot of trials were unable to recruit because the pandemic was rapidly controlled because of non-pharmaceutical or non-pharmacologic interventions. COVID-19 essentially is comprised of two distinct, two different components that we think of as being distinct, but really they bleed into one another. And these are the initial viral replicative stage and the immunopathogenic stage that leads to more severe disease. So really these two phases are addressed by different types of medications. The antivirals are obviously going to be targeting virus entry and replication. And then the immune modulators are the ones that are going to be more effective down the road when viral replication is no longer leading the disease. It's more a runaway immunologic phenomenon. So we're going to start by talking about virus-directed therapy. So as we know, SARS-CoV-2 infects respiratory epithelial cells. First, there's the docking of the S or spike protein that docks onto the ACE2 receptor. It results in membrane fusion. The virus comes into the cell, it dumps its genetic material, which is then translated and replicated. New virus is formed, and then this is exported throughout the body. So there's a number of different steps along this pathway that have been targeted with a number of different antivirals. The first one that I'm going to talk about is hydroxychloroquine, not because it was effective, but because it's a cautionary tale of basically everything not to do when investigating new therapies in the pandemic. So initially there was some in vitro data suggesting that hydroxychloroquine was able to limit replication of SARS-CoV-2 in the lab. There was initially a preprint from Didier Raoult's group in Marseille that suggested that there was a reduction in viral replication and some improvement in patient outcomes. Really, this was a tremendously flawed paper that had a lot of problems with selection bias. They excluded patients that had poor outcomes, and consequently, they overinflated any benefit of hydroxychloroquine. However, it didn't take long before there were some proponents that were promulgating the benefits of this medication, including the President of the United States, who tweeted one day after that preprint was published that hydroxychloroquine and azithromycin may be one of the biggest game changers in the history of medicine. A week later, the FDA issued an emergency use authorization, and there was a lot of excitement for this drug. And this is reflected in internet searches for hydroxychloroquine at the time that spiked, and then more importantly, prescriptions for hydroxychloroquine that had a slightly more sustained spike once it was exalted by the president and several other key opinion leaders. Now, it didn't take long before the pendulum swung the other way. There was a lot of pushback in the media by a number of different experts who were concerned about the president's message. And there were a number of reports that suggested that there may in fact be harm associated with the medication. Unfortunately, the effect of this messaging is that the general perception that hydroxychloroquine was very dangerous, which is not the case at all. This is the effect that it had on our outpatient studies of hydroxychloroquine. This is a study that was being conducted in a few Canadian provinces, as well as throughout the United States, and it was based on self-referral through internet enrollment. And so the study began recruitment just before Trump started tweeting about it. Initially, there was some enthusiasm among individuals. These are people who had either been exposed to SARS-CoV-2 or who had early infections of SARS-CoV-2. So they were, at this point, still actively seeking therapies. However, soon when the warning started to come in and there was a lot of concern about the safety of this medication, it became almost impossible to recruit. And one of the effects is that people were either scared of the medication or they were scared of being involved in somehow proving Trump right or proving him wrong. And the fact that this medication was available through outside channels, including all these physicians that were willing to prescribe it, made recruiting within a trial very difficult. And that's led us to the current state, which is literally dozens of clinical trials that have demonstrated that hydroxychloroquine is neither harmful nor beneficial. It in fact has no effect whatsoever. And this has been looked at every phase of the disease, from pre-exposure prophylaxis to post-exposure prophylaxis, and then early outpatient therapy and inpatient therapy. Basically, none of these situations has shown to have any promise for hydroxychloroquine. The most compelling data come from these two large adaptive trials, the recovery trial, which enrolled 4,500 patients to this question, either hydroxychloroquine or usual care, and demonstrated that there was no difference. And in fact, patients with hydroxychloroquine did a little bit worse. Similarly, the Solidarity trial enrolled about 2,000 patients and found outcomes were slightly worse with hydroxychloroquine. So this begs the question of, why were we misled that that we thought that this drug did have some potential? And part of it has to do with the fact that that in vitro data that I suggested before showed some benefit was using the wrong cell lines. So basically, kidney cells, which is what the Vero cells that initially demonstrated in vitro efficacy used, have one mechanism for SARS-CoV-2 cell entry, and this is a pH-dependent mechanism that is sensitive to hydroxychloroquine, which acts by increasing the pH. However, respiratory epithelial cells also have a pH-independent mechanism that is impervious to hydroxychloroquine. And so ultimately, there was no hope for hydroxychloroquine, but because this medication did not follow the usual linear pathway of taking drugs through development, this unfortunately was not a checkpoint that was heeded. The next medication, which is slightly more promising, is remdesivir. This is a nucleoside analog. It interferes with the viral RNA-dependent RNA polymerase. It was initially developed for hepatitis C. It was repurposed for Ebola. It did go to a phase 3 trial with Ebola, but it was ultimately shown to be less effective than monoclonal antibodies. There is animal data suggesting that it works in SARS-CoV-2 infection, and it was FDA approved and ultimately Health Canada approved July 27th. Now, the first really robust study evaluating remdesivir was the ACT-1 trial, which was led by the NIH. This is a double-blind, placebo-controlled trial, mostly in North America, that involved over 1,000 patients. The primary outcome was median time to recovery, and in fact, there was faster recovery among patients that received remdesivir, 10 days versus 15 days. There was hope that there would be some benefit in mortality. This trial, as I mentioned, was not powered for mortality, but with 1,000 patients, we hoped that there would be some signals there. And initially, when only the day 14 outcome data were released, it looked like there might be some daylight between the remdesivir and placebo arms on the Kaplan-Meier curve. And unfortunately, this did not maintain statistical significance at day 29, although whether it's clinically significant is another story. However, what is clear is that not all patients derive benefit from remdesivir, and in fact, patients who either don't require oxygen or who are mechanically ventilated appear to derive no benefit from this medication. On the other hand, patients that require low flow supplemental oxygen do benefit. So really the benefit that was seen in this trial is being driven exclusively by this one patient group, albeit a large patient population. However, more recently, the Solidarity trial published a much larger evaluation of remdesivir. So this is a multinational WHO-led adaptive open label trial. They used the much harder endpoint of in-hospital mortality, and they evaluated over 5,500 patients, half of whom received remdesivir and half of whom were randomized to standard care. Because of the open label nature of this trial, the effect on duration of hospitalization is, in my opinion, not reliable. Some of the patients may have been kept in hospital longer in order to complete their 10 days of remdesivir infusion. So I don't think this is a particularly helpful endpoint in this study, but in-hospital mortality is, of course, a much more objective and hard endpoint. And you can see that the overlay of Kaplan-Meier curves between the red for remdesivir and the blue for the control are indistinguishable, and essentially comes out as purple. The investigators did do a meta-analysis that included patients from the recovery trial as well as an earlier trial from China. Now they broke down the higher risk and lower risk not by oxygen requirements, but rather by ventilatory needs. So among patients who were considered lower risk or who were not receiving any ventilation, there seemed to be a smidgen of benefit that was almost statistically significant, but the authors went to great pains to caution that this should be interpreted with a lot of skepticism based on the fact that this was a post hoc subgroup analysis. The bottom line is that remdesivir really is the Goldilocks of COVID therapies. It seems to work, but only in the right patients. It doesn't work too early in patients who don't require oxygen, and it doesn't work too late. Once they're in the ICU, there is no value in giving remdesivir. And although it does not improve mortality in general, there is a subset of patients that will be benefited from this drug in terms of accelerated time to discharge. The next group of therapies that are directed against the virus are passive antibody therapies. So this is convalescent plasma or monoclonal antibodies. So these are antibodies that target the virus. Generally, they target the SARS-CoV-2 spike protein, and so they interfere with binding of that protein to the ACE2 receptors. There's two different types. There's convalescent plasma, which is a therapy that's been used for decades, in fact, for over a century. It's been used for a number of different viral diseases. It can theoretically be used as a prophylactic, or it can be used as a therapy. There are risks associated, including a transfusion-associated cardiac overload, transfusion-related acute lung injury, and thrombosis. There is theoretically a risk of bloodborne infections, although in practice, I think this risk is very low. There is a risk of sensitization in patients who may require further transfusions or who may require transplantation. Theoretically, for both convalescent plasma and monoclonal antibody therapy, there was a risk of antibody-dependent enhancement of disease. This is something that's seen in dengue, where the second time that you get dengue is more severe. And this risk was not borne out in SARS-CoV-2. So the largest data set for convalescent plasma comes from the Mayo Expanded Access Program that was then converted into an expanded use authorization from the FDA. Through this program, initially when it was the Expanded Access Program, 77,000 patients were transfused. In total now, over 105,000 patients have been transfused in this program, which means that these patients were not enrolled in randomized controlled trials. In my opinion, this was a massive squandered opportunity to be able to generate high quality data. The argument is that some of the sites where these patients were cared for didn't have the capacity or the infrastructure to be able to do trials, but certainly if only one a small proportion of those patients were enrolled, we would definitively know whether this therapy works. Instead, what we're left with is a within-group analysis that basically shows that patients that received higher doses of the antibiotic, so higher titers, did better than those that received lower titers, and those that received it within 72 hours did better than those that received it later. So there is some biological plausibility based on this, this dose response, but this is far from the sort of data that we would really expect to be able to make clinical decisions. Now, the Mayo group and their collaborators have done a meta-analysis of observational studies shown on the bottom here that show there is a benefit. And of course, as we've already seen, this is a common common motif in COVID-19 therapy investigations, where observational data suggests something works, and these benefits are not borne out in RCTs. There have been 3 RCTs of convalescent plasma. The first one from China was aborted early because of control of the pandemic. The second one was in Holland and Belgium. And this one stopped early because 80% of patients actually already had antibodies at titers that were as high or higher than what they were being infused with. And so the Data Safety Monitoring Board suggested that this was really futile. The third one, which is the most robust data that we have to date, is from India. It's an open label study. In this study, antibody titers were not available before transfusions, and some patients received low titers, and certainly lower than what's recommended by the FDA. Nonetheless, it showed there was no benefit within this setting. So the bottom line is that there's no RCT data to support convalescent plasma. It does appear to be reasonably safe according to this observational data from Mayo. It may work early in therapy and in less severe disease, and particularly when high titers are used. Now, the caveat is that the titers are often not known at the time of infusion. There's only currently one FDA-approved test to evaluate the titers, and so this is a major limitation. Clinicians should be aware of some risks, including lung injury, cardiac overload, and thrombosis, and there are RCTs ongoing. The recovery trial in the UK has already enrolled over 2,000 patients to either convalescent plasma or to usual care. And in Canada, we have the Concord 1 trial, which is ongoing, and hopefully will resolve this issue. Monoclonal antibodies are basically the rich man's convalescent plasma. This is the use of an individual antibody or a cocktail of antibodies that have neutralizing activity against SARS-CoV-2. Generally, these target the spike protein, and there are some theoretical advantages, including the fact that you know exactly what the titer is of antibiotics that you're infusing into the patient. There are no risks of bloodborne infections or sensitization. And these therapies are being evaluated both in inpatients, in outpatients, and as prophylaxis. Bamlanivimab, also known as LY-CoV555, is the Eli Lilly agent that has recently made some headlines because it was granted EUA approval earlier this week. So this is an IgG immune globulin. It does have some data for it in the outpatient setting. BLAZE-1 was a phase 2/3 RCT of outpatients. There were 3 investigational groups and a placebo group. So the different titers of monoclonal antibodies were evaluated, and the primary outcome was a change in viral load from baseline. And what the investigators found is that one of those doses, the middle titer, did lead to faster viral load decay. However, the other two, both the high and the low doses, did not, which to me suggests that this is probably a chance finding. There was a decrease in hospital visits or emergency room visits in the patients that received the monoclonal antibody, but the event rate was so low that the confidence interval is absolutely massive. I would argue that we really don't have enough data to advocate its use. Regeneron REGN-COV2 is a monoclonal antibody cocktail. So there's two antibodies, pardon me, both of them acting against the spike protein, and they're infused in combination. We only have data from a press release. There's virologic data suggesting that the viral load decreases faster than placebo. This seems to be the greatest with the high dose infusion. On the other hand, the clinical data suggests symptom improvement with the low dose as opposed to the high dose. So again, there's this discrepancy that makes us question the plausibility of these benefits. There was a reduction in hospital visits, again, low event rate, and we need to see the data. It hasn't been published yet. Of course, this is the therapy that gained fame or notoriety because it was used for President Trump when he was admitted to Walter Reed Hospital. And really, that's the sort of scenario that we expect this to be of benefit, is very early on in the course of therapy, within 3 days, 4 days from symptom onset, before the individual has developed their own antibodies. After they've developed antibodies, unlikely that there's going to be any meaningful benefit, and perhaps there could be harm. We don't know yet if this is going to interfere with the ability to mount one's own antibodies to be protected against subsequent reinfection. We don't know how this is going to affect response to a vaccine. So there's still a lot of unknowns. It doesn't seem to work at latent disease among inpatients, although it is being investigated still, the recovery trial. I can tell you both the Regeneron product and the Lilly product had phase 3 trials that were stopped in the last couple of weeks because of a lack of efficacy. It may work in very select circumstances, like for very high risk outpatients or for presidents. The barriers are, of course, that it requires an infusion, and I don't see a COVID-19 outpatient parenteral antibiotic program anytime soon. The low event rate among outpatients in general mean that there's going to be a very high number needed to treat in order to see any benefit. And the projected cost is probably going to be in the range of at least $3,000 US per course. And so, given the numbers that we're going to need to treat to prevent even one hospitalization, it's really hard to fathom that this is going to be a treatment that's going to be an option in Canada. Moving along, so after the virus infects the cell, there's activation of the cell's inflammasome that leads to cytokine release. These cytokines recruit macrophages that then themselves are stimulated to release further pro-inflammatory cytokines, lead to additional macrophage and neutrophil recruitment, and both endothelial injury locally in the lungs leading to ARDS, as well as systemically leading to septic shock. So the idea is that by blocking some of these cytokines, that it may be possible to improve outcomes. And early in the pandemic, there were a lot of observational studies that suggested severe outcomes were associated with the so-called cytokine storm. In my opinion, this is a histrionic term that hasn't been shown to have any clinical value. It's not a well-defined phenomena, and that makes it very difficult to study. Nonetheless, there's over 60 trials that are ongoing that are evaluating different products at different stages of this inflammatory cascade. There is a theoretical risk, and some of that risk has been borne out in terms of increased risk for infection. Once again, retrospective matched cohort studies have suggested benefit, as we've seen with convalescent plasma, for example, as we saw with hydroxychloroquine, as we saw with lopinavir, ritonavir. Ultimately, this has not translated into any benefit in randomized controlled trials. There's been a number of phase 3 trials for both a sarilumab and tocilizumab that have been stopped by the sponsor because of lack of efficacy. Only 2 of them have been published, both for tocilizumab. The COVACTA trial is the largest so far, it's 452 patients, demonstrated no benefit in mortality or in clinical status. IMPACTA is another study of tocilizumab that was also placebo-controlled. There was no difference in mortality, but there was a reduction in the need for mechanical ventilation. And then 3 smaller trials that were underpowered have failed to demonstrate any mortality benefit. So the bottom line is that tocilizumab looks really good in observational studies. If you guys recall, earlier in the spring, we had a speaker from Italy who conveyed a sentiment that we heard a lot around that time, which is that the benefit from tocilizumab was so evident that after just 2 or 3 patients, it was clear that this was an effective therapy and that it was not ethically justifiable to randomize patients to not receive this therapy. Of course, here we are 10 months later, we still have no idea if it works. And so we look forward to additional data. This is being evaluated in the recovery trial, so we will have definitive data. It's just a pity that we didn't have this months ago. The one bright point in the pandemic in terms of therapies is corticosteroids. Now, initially, there was a lot of reservation in encouraging corticosteroids, and this is on the basis of other viral infections like SARS and MERS, in which corticosteroids were associated with increase in viral shedding, and influenza, in which corticosteroids are associated with increased mortality. So there was initially a lot of skepticism, but this made the results of the recovery trial all the more remarkable. And so this, again, is a open label adaptive trial in the UK. It really is a remarkable undertaking. Most hospitalized patients with COVID-19 in that country were enrolled. Basically, the investigators made it more accessible to be in the trial than to not be in the trial. And so there was a lot of there were a lot of barriers to enrolling patients that were addressed on a systematic basis. What the investigators found is that dexamethasone at low doses at 6 milligrams a day, either IV or PO, had a mortality benefit in comparison to usual care. And there were 6,500 patients that were included in this arm. There was overall a 27% relative risk reduction. This benefit is most pronounced among patients in more advanced stages of disease. So those patients requiring mechanical ventilation had a 36% relative risk reduction and absolute risk reduction of about 12%, which is really astronomical. Now, I should point out that in the recovery trial, the mortality rate of COVID-19 was much, much higher than what we've seen in North America and what has been seen in other North American trials like ACT-1, for example. And so there is question of whether this benefit is going to be as pronounced in other settings where the mortality rate isn't quite as high. In patients that were requiring oxygen, there was still a mortality benefit and absolute risk reduction of about 3%. And among patients who didn't require any oxygen, there was no benefit. In a pre-specified subgroup analysis that looked at the mortality benefit based on the time from symptom onset to therapy, there was clearly more of a benefit in patients who were treated after 7 days of therapy. And And again, this is when we expect that inflammatory phase of the disease to really be in full swing. Now, this is in contrast to SARS or MERS, where it's in the second week of a disease that actually has the highest viral shedding, whereas in SARS-CoV-1, it's very early in infection that the viral replication is the highest. And that may be why we see benefit in COVID-19, but not in those other diseases. Once the results of the recovery trial were announced by press release, there was quite a dilemma in that there were a number of other studies that were evaluating corticosteroids that ultimately decided that it was no longer ethical to withhold corticosteroids from patients. And so these studies all ended up stopping early so that everyone can be offered corticosteroids. There were 3 such studies that were all underpowered that published in September in JAMA, along with a meta-analysis that was conducted by the WHO. And despite the fact that these studies were underpowered, when combined with the critically ill patients in the recovery trial, there was clearly a consistent and robust benefit to corticosteroids. And it suggests that this is a class effect, although given that the low doses seen in the recovery trial seem to be at least as efficacious and probably are associated with lower adverse events, this seems to be the preferred dosage to be used. The bottom line is that corticosteroids should be used in patients who are critically ill in the absence of a clear contraindication. It should also be used in patients who are requiring oxygen and should not be used in patients that are not requiring oxygen. In general, results from interferons have been disappointing. They've generally been evaluated in combination with other therapies such as lopinavir, ritonavir, or ribavirin, and generally there hasn't been a benefit demonstrated. However, interferons are still being evaluated by the NIH in the ACT-3 trial. Yesterday, there was a study, a pilot study published in Lancet Respiratory Medicine. This is a study from the UK where 101 patients who were hospitalized with severe COVID-19 were randomized to inhaled interferon beta 1A or to placebo. The primary outcome was a change on the WHO ordinal score for clinical improvement. 2/3 of the patients that were enrolled required oxygen, and the results are shown on the right side of the screen. You can see that the proportion of patients who recovered, which is defined as the ordinal score 1, or in other words, no limitation in activities without oxygen, was higher in patients that had the inhaled interferon beta 1A. And so this is preliminary data and needs to be confirmed in phase 3 trials, but it is at least some cause for hope, which is generally rare these days. So looking at that fearsome landscape at the beginning of the talk, a lot of these agents have been proved to not be effective. There's only a few that are left standing. Interferon is on one leg. Tocilizumab, probably you could say it's on one leg. The book isn't shut altogether. Convalescent plasma, similarly, it hasn't been shown to be effective, but hopefully we'll have definitive data from the recovery trial. And steroids in particular remain the brightest spot, and remdesivir is alive but not well. So what's on the horizon? I had teased that I would divulge sort of where things are going, and really this wasn't fair because I have no idea. I can tell you that in terms of antiviral therapies, it's quite clear at this point that inpatient antiviral therapies are going to have very limited efficacy. And so, whether it's early outpatient antivirals through an IV therapy like remdesivir or monoclonal antibodies, or an inhaled version like inhaled remdesivir, which is being evaluated, this seems to be the only way to really have benefit from these types of agents. However, as I mentioned, the event rate in COVID-19 among outpatients is so low that the number needed to treat is going to be enormous. And so the feasibility is going to be quite limited. Combination remdesivir and dexamethasone is done very widely, but it's unproven. Currently, there's no RCTs that have evaluated this strategy. There's unlikely to be any that are sponsored by Gilead, because it's very likely that there's no additional benefit to remdesivir on top of dexamethasone. But hopefully somebody will do that study. Currently, the recovery trial is evaluating a few therapies that they think are promising, including aspirin, which has just been added.
Are you done?
No, sorry. Sorry about that. I had my BBC Dad moment. Aspirin, azithromycin are being evaluated. In addition, they're still looking at this Regeneron monoclonal antibody and Tocilizumab. And the Solidarity study is looking at remdesivir. And a monoclonal antibody is to be added still. I think we'll just skim through this. Basically, there's a few overarching lessons from the pandemic. The first is, the cavalry is not coming. We're not going to be saved by any therapy. There's no magic bullet. And so we really need to be embracing sensible medicine, which is supportive restraint and heightened therapeutic humility. So we need to practice doing nothing. We need to elevate usual care and focus on high quality evidence. We really need to be prioritizing RCTs. The difference between observational data and RCT data couldn't be more stark. It's like the Four Seasons hotel and the Four Seasons total landscaping. The major challenge with observational data is that it is meant to inform assumptions for RCTs. We're not supposed to be making treatment decisions on the basis of this. And unfortunately, this has hampered enrollment in RCTs. And we've seen this in hydroxychloroquine, in Tocilizumab, and most recently in convalescent plasma. We need to be leveraging adaptive clinical trial designs and clinical trial networks. There have been a number of excellent exemplars within COVID-19, including the UK recovery trial, the ACT trials in the United States, CADCO and the Solidarity trial, and REMAP-CAP. And we need to be pushing back on the politicization of medicine and science. And I think this is something that comes down to all of us. We all need to be engaged and engaging with individuals, not because we're going to change the minds of those individuals that are zealots, but because there's a lot of other people that are paying attention. In conclusion, the landscape of proven or promising therapies is very sparse. We're not going to treat our way out of this pandemic. We need to prioritize generating high quality RCTs, and what we learn or what we fail to learn from this pandemic is really going to define our preparedness for future pandemics. I'd like to close by acknowledging a colleague in Texas, Brad Cottrell, who has been very helpful in generating this talk. And my family. You met my son, Solomon, and we did not get a visit from Annalise. But thank you very much for your attention.
Thank you, Ilan. That's great. We got a nice observation of Dr. Dad at work. Ilan, I just wanted to start by asking around the idea of precision therapy. And, do we have any data yet in terms of is there any opportunity for targeted therapy, not so much with steroids, but with some of the other drugs? Has there been any evidence that's been put forward that some populations may benefit more? You talked about presidents, but any other populations that we can personalize to?
I'm sorry, I missed the first part of your question about. Personalized
Sorry.
therapy?
Yeah. So is there any evidence that any of these,
Precision therapy,
yeah,
so far, no. We don't have that level of granularity, even when it comes to knowing, which patients are going to benefit from things like Tocilizumab, for example. Some of the criticism has been that the patients that were involved in these trials were not selected carefully enough to know who would go on to develop these inflammatory syndromes. And that's always going to be a challenge is selecting the right patients for an RCT, and it's something that's always easier to do in retrospect when picking up the pieces. But so far we haven't demonstrated that we have the ability to do that.
We're going to go a couple of minutes over time. I'm just going to address a couple of questions in the chat box. One is a quick one. Are the data with interferon alpha or lambda? Do you know?
It's interferon.
We can get back to the questioner.
It's alpha, beta 1A.
Okay.
Interferon beta 1A.
And then the last question is around people on chronic steroids for other diseases. Is there any evidence of the impact of I guess, disease of COVID on these patients? Presumably they're immunosuppressed and that's why they're on steroids. But is there any data around the impact of disease and in patients who are on chronic steroids?
So there's a lot of observational descriptive data of patients with various immunodeficiencies, and the overarching signals from these studies is that patients who are immunocompromised have more or less similar outcomes to everybody else, perhaps a tiny bit worse in some settings, but certainly not dramatically so. The question is what to do with their immunosuppression, and I don't think this is well addressed, certainly not by any prospective studies. I think that it would be reasonable to give somebody pulse steroids if they're on chronic low-dose steroids when they are hospitalized, as you would do for any acute illness in someone who's adrenally depleted.
All right. I'm just cognizant of the time. So thank you so much. Despite, all the little technical difficulties and the great little visitor, this was an outstanding round and really timely and well done. Thank you so much. Just a reminder for everybody that we are going to have a chat with the chair at noon today. So there's a different sign on for that. We're going to start a new series in our grand rounds. It's not really new, it's just a reboot of our Bench to Bedside series. And the first one is going to start next week with Dr. Andy Mason. So just stay tuned for that. Thanks everybody. As usual, we will post this rounds and we'll try and get some of the questions in the chat box answered in the posting. Have a great day and stay safe.